So the first speaker this afternoon is Ian Tan from Singapore. And Ian's going to talk to us about heart-lung interactions, impact on survival. We've had background talks on heart-lung interactions and on the cardiovascular system. Ian will take us to the point where does it affect survival?
Thank you very much for that too. Okay. Well, if I had to talk about evidence basis for heart-lung interactions and their impact on survival, I might as well end my talk here. There really isn't any evidence-based randomized controlled trials looking at the effects of heart-lung interaction and improving survival. But this one area of survival is how we manage to survive medical school and understand all of these complex interactions. And of course, now when we start practicing, how we survive these questions from medical students. Well, I'll go right back to when I was a little kid and I was taught what is right and what is wrong. And I'll start with this one. The arterial pressure is equal to the cardiac output multiplied by the arterial resistance. Therefore, the cardiac output is equal to the pressure divided by the resistance. Is this right or is this wrong? I would say that this is mathematically correct, but it is physiologically wrong. In this situation, the blood pressure is the dependent variable, and it is not the cardiac output. And the right way to write these equations is to put the dependent variable on the left side, and it is a function of the different independent variables. So this is correct. The pressure is equal to the cardiac output multiplied by the arterial resistance. And this is wrong. The cardiac output is not the pressure divided by the resistance. You've seen these graphs before, and I know yours. And I would like to, first of all, look at this one. This is the Frank-Starling curve. As right atrial pressure increases, cardiac output increases. Is this right or is this wrong? Well, clearly this is right. This is an experimental finding. Well, let's take a look at the other curve. You've seen these curves before. And this is Guyton's curve, and you see increasing right atrial pressure decreases venous return. And this is the equation. Venous return is dependent on the right atrial pressure. Is this right or is this wrong? Well, I'm going to stick my head out here and say that this is wrong. Guyton's experiments were done with flow as the independent variable. You can't put the independent variable on this side of the equation. This is how it should actually look like. As cardiac output increases, right atrial pressure falls. And this happens because the heart, as a pump, it sucks blood out of the right atrium. And the harder we run the pump, the more blood is sucked out of the right atrium, and therefore the right atrial pressure falls. And this is the actual equation that we should be looking at, right atrial pressure as a function of the independent variable, which is the venous return. The venous return is the cardiac output. And it's important to look at this waterfall. The venous return cannot increase when the veins start to collapse. And this is what we also see in chronic obstructive airway disease. There is flow limitation. No matter how much or how negative we put the airway pressure, flow cannot increase. And, well, if there are no surgeons in this room, but I think this is also what happens when we try to pass urine. The urethra will start to collapse. No matter how hard you try to strain, you cannot increase flow. It's limited. We've done bathtubs before, but I just want to reiterate that there is a certain stress volume above which you get this mean systemic filling pressure, and the unstressed volume does not contribute to the flow. And again, as the veins constrict, the heart expands. So this again is an independent variable. The veins can constrict. And this is a relationship between our blood volume and the mean systemic filling pressure. Well, I'll move on now to heart-lung interactions. And when I talk about heart-lung interactions, I'm looking at the mechanical effects of ventilation on circulation. We had a very interesting discussion yesterday at the panel session, and there are actually many different heart-lung interactions. It's not just the mechanical effects. There are also neural effects. There are also humoral effects. And there are also changes in blood gas. For example, if we increase mechanical ventilation, we don't just increase the pressure, we also alter CO2. And this also has effects on, for example, the pulmonary artery pressures and its effects on lung edema. Well, there are three components to the circulation. There's the pulmonary vessels, the heart, and the systemic vessels. And I've divided them into pulmonary, extra-alveolar, and alveolar blood vessels. And yesterday there was a very nice diagram. The extra-alveolar blood vessels are those in between the alveoli. As the lung expands, these blood vessels are stretched, and these were the ones that would rupture at very high lung volumes. And the alveolar blood vessels are those that are in the alveoli lining itself. When the lung expands, these are the ones that get squeezed. And when we look at that kind of a model, there are actually four applied pressures that we are interested in. There's the alveolar pressure inside here, the pleural pressure, the pericardial pressure, and the abdominal pressure. And when we talk about heart-lung interactions in this context, we want to look at the effects of these four applied pressures on these three components of the circulation. At constant lung volume, there's actually no difference because both of these pressures will increase or decrease at the same time. The effect of changing these pressures is actually on the heart and the systemic circulation. So it doesn't matter if the patient is spontaneously breathing or IPPV, or for example, if the patient is having a sustained inflation as a recruitment maneuver, or PEEP, or Valsalva maneuvers, the effect is on the heart and the systemic circulation. This is different when the lung volume changes. As lung volume increases, extra-alveoli blood vessels dilate. And these alveoli blood vessels get stretched. And the effect on the systemic circulation in terms of blood pressure and cardiac output depends on the blood volume. If the patient is hypervolemic and there's a lot of zone 3, then stretching these vessels will squeeze blood out. On the other hand, if the patient is hypovolemic, stretching these vessels actually makes no change to capacitance of the pulmonary blood volume. And the only change is that the right ventricle now pumps against alveolar pressure and blood flow becomes independent of left atrial pressure. And here are the effects on the systemic circulation. As I mentioned before, any changes in pleural pressure is actually an indirect effect on the abdominal pressure. The diaphragm moves down and abdominal pressure moves up. And this is very important because this affects our mean systemic filling pressure. And this is important because abdominal blood vessels form 50% of systemic capacitance. So let's consider the situation of IPPV, a patient with a relaxed diaphragm, and all of these pressures will increase with a positive breath. If the patient is hypervolemic, these blood vessels are squeezed and the mean systemic filling pressure increases. However, this pressure increases at about the same rate as this one. So the gradient for flow actually remains roughly the same. If, on the other hand, the patient is hypovolemic, there's really no bathtub here that increases the systemic filling pressure. And because this now increases and there is no increased gradient for flow, hypotension results. Looking now at the patient who is spontaneously breathing, this pressure decreases and this pressure increases. So here, the IVC gradient for flow will increase. And if the patient is hypovolemic, means systemic pressure doesn't increase, and IVC gradient for flow may decrease. Okay, so That's a very brief summary of medical school. In the interest of time, I'm not going to talk about Kussmaul's sign and Paul's paradoxes and all those other heart interactions, but they're also potentially very interesting. Well, we've survived, but did we help our patients to survive? Well, we think we know what we're doing. We think we know what IPPV does to the blood pressure. But it presupposes that if we know what we want to do, what blood pressure do we want? We haven't even answered this simple question. My patient is septic. What is the right mean arterial pressure? Is it 60, 80, 90? We still don't know. What cardiac output do we want in our patients? Is it 3, 4, 5, 6, 10, 20? We still don't know. Do we know what is beneficial? Did we ask the right question? Did blood pressure actually matter to survival? We still don't know. Well, again, let's move back to IPPV. This is our patient, sedated, paralyzed, and shocked. As we increase lung volume with IPPV, pulmonary vascular resistance decreases. The pulmonary blood volume increases as we increase lung volume. We've discussed before that the venous return can fall. And this also is true for the left atrium. But the left ventricular afterload decreases. You're increasing the pressure here, squeezing blood out of the system. And in the systemic vessels, inferior vena cava flow decreases. And if you add up all these different factors, the end result is that hypotension in most patients is worse. Is this a bad outcome? We think it is, but is it really so? Well, look at this one. I was very interested when this paper was published. These people looked at their patients, they sedated and paralyzed them, and you look at the lactate levels. Mechanical ventilation actually decreased hyperlactatemia. But I just told you that blood pressure fell, and so did the cardiac output. Mechanical ventilation induced hypotension did not negate this benefit. What is going on? Why are these patients doing better even though the blood pressure and the cardiac output are lower? Well, long ago, we knew that spontaneous respiration actually requires quite a lot of diaphragmatic blood flow. And you can see what mechanical ventilation does to the diaphragmatic blood flow. It decreases diaphragmatic blood flow. There it is. And 60% increase in diaphragmatic blood flow with spontaneous respiration. And this is true too with shock. As the patient goes into shock, as a percentage of cardiac output, if the patient is spontaneously breathing compared to that of mechanical ventilation, diaphragmatic blood flow increases from baseline of about 3% to over 20% of cardiac output. Very little change with mechanical ventilation. So if we do the reverse, that is why the patients did much better and reduced their lactate levels when they were ventilated. But is that also important for survival? We have reduced the patient's work of breathing. We've redistributed perfusion away from the diaphragm to other organs, for example, the gut, and that is why the lactate is lower. Is this important for survival? I think it is. But do I have randomized controlled trials to show this? No, I don't. Well, there may not be a randomized controlled trial in humans, but here's another one that's looking at a 100% lethal model of septic shock. These were Sprague-Dawley rats. They were all injected with E. coli, and you can see they were randomized to inotropic support and also to mechanical ventilation. Here you have the mean arterial pressure, and here is the survival time, which is essentially what we're looking for in supportive therapies. We want to prolong survival so that definitive care can take place, take effect. And here is the control group, the placebo group. Comparing the placebo group to those with rats not mechanically ventilated, the giving an inotropic support to improve the blood pressure made very little difference to the survival time. On the other hand, if the rats were mechanically ventilated, there was a very significant prolongation in survival time. And adding inotropic support made no difference to survival time. There was no evidence that vasopressor therapy improved the duration of survival. but there was a highly significant prolongation of survival when animals were mechanically ventilated. In other words, if we try to treat the cardiovascular system and the hemodynamics, our patients just died with a better cardiac output and blood pressure, but they still died. But if we ventilated them, they did much better. So I would say that full ventilatory support is indicated when patients are shocked. We want to relieve the work of breathing. We want to reduce their oxygen consumption. We want to avoid diverting blood from the vital organs to the diaphragm. And this improves the perfusion of vital organs. I don't have any randomized controlled trials to prove this. This is what I think is happening. We've seen this data before, and here's another fine example of heart-lung interactions in the setting of a recruitment maneuver. 3 different recruitment maneuvers: a sustained inflation, incremental PEEP, pressure control ventilation. You've seen this data only in the last lecture, and more important than what method you use, but very interestingly, look at the cardiac output. It has come from a baseline, 30% of normal. And just 5 years ago, we were doing sustained inflations to all our patients without knowing this data. Is there ever going to be a randomized control trial on this? I don't think so. Look at that. Here's another one. And those of you who know me know that I'm a great fan of APRV. And this increases cardiac performance in patients with acute lung injury. And here's the data. Much less paralysis, much less sedation, much less requirement for pressors, and a higher cardiac index. Does this improve survival? Better urine output? Well, there might be some improvement in survival, but is it due to the hemodynamics? These patients were quite different. One was sedated and paralyzed, and the other ones were not. It might be that the sedation and paralysis is bad. It might be nothing to do with the heart-lung interactions. It might just be the sedation and paralysis. I cannot say that spontaneously breathing patients have a better outcome because they are spontaneously breathing. It also means that I cannot say that increased cardiac output was the cause of the better outcome in terms of length of ICU stay and the length of ventilatory support and survival. It might be that the benefit is due to other reasons. Spontaneously breathing patients have a much better recruitment in the dependent areas of the lung. And I'm sure you can look up all of these data with and without spontaneously breathing, and you can see a much better end expiratory lung volume in patients with spontaneously breathing. And how about when we wean patients off ventilators? Again, when we wean patients off the ventilators, the pleural pressure here decreases and the abdominal pressure increases. Spontaneously breathing compared to IPPV. The lung volume decrease can dilate the alveolar blood vessels. Venous return increases, afterload, left ventricular afterload will increase. And for systemic vessels, inferior vena cava flow will increase. And if the patient has a normal heart, this increase in preload will increase its cardiac output. For patients with heart failure, the afterload dependence causes decreased cardiac output and pulmonary congestion. And here again is some data to show this. As patients are weaned, if they are successful, they can defend, they can compensate for this. But if they fail to wean, they will divert their perfusion into the diaphragm and causing some ischemia in the gut. And finally, I would like to deal with hemodynamic monitoring and whether it improves survival. And more recently, we have been looking at fluid responsiveness and whether it improves, does this also improve survival? We are quite familiar with this systolic pressure variation as during inspiration, venous return falls, and the systolic blood pressure will fall. And this variation is called the systolic pressure variation. And there are many other different ways to look at fluid responsiveness in the patient. But what do we do with this? So we have a patient who has a reasonably large systolic pressure variation. Are we going to give fluid? If we give fluid, what kind of fluid are we going to give? Does it matter? Do we give diuretics? Should we give a vasopressor, a vasodilator, or inotropes, or a combination of the above? Should it be done with a protocol or without a protocol? Well, here's a study that I'm sure most of you are very familiar with. This is the pulmonary artery catheter trial in the French group, looking at early use of the pulmonary artery catheter. They had patients enter into the trial if they were shocked and ARDS. And you can see, even if we knew the patient's cardiac output, many different hemodynamic parameters, it made absolutely no difference to the outcome. Does it matter if we get these numbers from a different method, non-invasive methods? It doesn't matter if we get it from extravascular lung water or many other different parameters. We don't know. We have been looking at just a univariate influence on survival, but actually mortality may be related to the interactions between many different things and not just hemodynamics. Here is an uncontrolled hemorrhagic shock model. This is a very famous one where they chopped off the tails of rats and allowed the rats to bleed in an uncontrolled manner. These rats were divided into 4 study groups. The first, they were resuscitated to a mean arterial pressure of 80 without blood. In the second group, they were resuscitated to a pressure of 80 with blood. And in the third and fourth groups, they were resuscitated to a mean arterial pressure of 40 with and without blood. And you can look at the survival. If we want to resuscitate our patients to a pressure of 80, we should give them blood. But if we need to resuscitate them to a pressure of 40, it made no difference whether we use blood or we use crystalloid or colloid. And you can look at the differences in the various other parameters. And again, if one wants to resuscitate patients without blood, the lactate goes up very high, whereas with blood, lactate doesn't rise as high. And if patients are given hypotensive resuscitation, it didn't really matter what fluid we used. And it might also be the interaction of hemodynamics with time. And very long ago, we've seen these 2 papers looking at time, taking longer than 24 hours to attain supernormal values, increased mortality. And again, volume loading of 40 mils per kilo in the first hour improves survival. And early goal-directed therapy, increasing all of these things, improve survival in many reverse trials. It might not be the hemodynamic parameters which they were looking at that was important in survival. It might be the time. Well, I think I've exceeded my allotted time, and I'll end here, and thank you for your attention.
Thanks very much, Ian, for a very clear presentation. If I got it right, I think Shelley might have a question or 2 for you. There are clearly differences in the model that Shelley presented and that you presented early on. So I'd be interested, within reasonable time, maybe have a little discussion. Can we have a microphone up at the front, please?
Well, there's not totally. There's only one small one, and he's chosen to use the Levy-Bringelman view of the circuit. And I think, and as a matter of fact, I have to write something about this coming up for July, so it's good practice, with Bringelman, a pro-con debate. I think the problem is, I still disagree with you about the right atrial pressure being the dependent variable. For example, if you actually just let the veins drain, as I said, you will get venous return. You don't need a heart to pump it. So I think the mistake in the Levy argument is it views the cardiac output, the heart, as the source of energy for the process, where I would view the energy as the elastic pressure stored up by the volume in the compliant region in the bathtub. And rather than saying the heart is actually creating the force, as you said, sucking, it's not sucking. I think it's being permissive. In other words, it's almost like a water wheel. water wheel. It's just allowing the volume up and keeping it going rather than actually providing an energy that creates the flow. And to me, I think that's the essence of the error in their approach. But otherwise, everything else, I would agree with this.
Yeah, I'm familiar with those arguments, and actually the independent variables are the ones that deliver energy into the system. So in your model, the energy is delivered by the vascular system, but that doesn't mean that the heart doesn't work. And when we connect the patients to the ventilator, there is another source of energy into the system. It's the machine as well as the patient's diaphragm. And all of these interact and they deliver energy into the system. So again, I
think they're minor, though, frankly.
Yeah. Yeah.
Actually, before you go on, Shelley, let me ask, from a clinical perspective, what's the difference which model we use? Does it affect the way you take care of patients? How is the different model, or is this just sort of a theoretical argument about which came first, the egg or the chicken?
I think it does make a difference in the sense that I think there's been an overemphasis on thinking about the heart in the process. Whereas if you realize that the heart, most of the time, and say extreme disease, it won't, it just basically keeps up with what it's given, then you really have to pay attention to what it's given. And then you can obstruct that by changing the pressure in the chest with a ventilator.
Talk a little closer.
So that could be affected by changing the pressure in the chest with a ventilator, various other factors. But how the heart, what it gets, becomes a very important variable. And then it makes you much more sensitive to that role of the right atrium and how it's being regulated. And then not looking at the arterial pressure as much either. So it does turn your view around, I think, quite substantially, in my mind.
What do you think, Ian?
Well, I don't think it actually really makes a difference. I think to me it is do we have any randomized controlled trials to look at the differences in outcome by targeting different strategies. And it doesn't really matter which way we think the strategies work. What your question is, does it work? And we still don't know that.
I would say that, I'm actually a fan of clinical trials, or some people, John isn't here, is not a fan of RCTs. But there's some things that I don't think we need an RCT for. I think that, whether you put a patient on some sort of ventilatory support with ARDS, severe hypoxemia, I don't think we have to do a clinical trial and show that more people die if they don't get ventilated, or there are many examples like that. So I think that it's useful to have randomized control information, but for many of the basic things, I'm not sure that it's entirely required.
Yes, but the problem is the basic things we're still not sure about. What blood pressure should we target in our septic patients? What cardiac output should we target our septic patients? We can't really know. I mean, we can think in terms of different models what it should be. We know what will happen when we do certain things to the patient, but we still don't know whether it's beneficial or not beneficial. And I think we need a large database.
So the question I asked Shelley and you was, would your algorithm be different if you used Shelley's model of what the independent variable is, or would it be different if you used your model? Any kind of algorithm for treatment of hypotension and sepsis, whatever, would there be a difference in the algorithm? I mean, I know we're talking theoretically in a sense. Shelley's thinking. Very unusual. I've never seen you like that, Shelley.
Well, I think it helps if you're trying to understand how ventilation interacts with the heart. I think the Guyton model, provides an easier way to think of it, because then you have this cardiac function curve moving in interaction with a venous return curve. And I think then the heart-lung interaction becomes, to me, quite simple. Is when you get away from that, it becomes, especially when you plot those curves the other way, the way Levy does. I mean, it's just very hard for me to actually get oriented and to think of it. I think Guyton gave us such a nice approach of having those two on the same axis, and you can see how beautifully they interact. And I guess the Bringelman argument argues that it's not really an interaction that's important, that the heart's sort of driving it, which just doesn't work for me.
Are there any other questions for Ian?
But there is, on the other part, the one you brought up too was the Roussos work, who was my previous mentor and started out my career looking at blood flow and respiratory muscles. And I think actually the Virus study and the OBA study, which are the two they did on this, they argued that there was a redistribution of flow, that the diaphragm actually and respiratory muscles actually stole flow. I think they were actually close, but not quite right. And what probably is happening more is that as you have the increased work of breathing, you increase afferent activity from the muscles. And so you actually have a very active redistribution of flow and a vasoconstriction that's going on and many other factors, which you then remove by a ventilator. So I think they're right that the ventilation is absolutely important, but more important than they realized. It was a much bigger issue. It wasn't just the steel issue. It's actually a true active sympathetic stimulation. And so the whole metabolic process just quiets down. Because you pointed out it was 20% of the flow. 20% of the flow in a shocked dog. And those dogs had flows that were about 500-600 mLs as compared to normal 3 liters in an animal. So that's 20% of a very low flow. As compared to a normal cardiac output, it's not that big a flow. And the highest in any studies I ever did was, just with oleic acid and just having the animal going full blast, was 11% of a normal cardiac output. Couldn't get higher. It's not that big.
Yeah, I completely agree with that.
Great. Thank you very much, Ian, for